Hello everyone. Now today we will be continue our nephrotic syndrome lecture, where we have discussed about the pathophysiology of nephrotic syndrome in first with clinical phases in first lecture. Then we have talked about the minimal change disease and focal segmental glomerular sclerosis. Now we will be discussing about the two systemic causes of your nephrotic syndrome, and that is amyloidosis and diabetic glomerular nephropathy. You have learned about amyloidosis in the pathology chapter as well, but here we need to understand that this amyloidosis, that is the systemic presentation of amyloidosis, there may be localized, there may be systemic. Since we are talking about the systemic presentation of the amyloidosis, the kidney is the most commonly affected involved organ in case of systemic amyloidosis. Okay, so you have to remember kidney is the most common organ involved in the systemic amyloidosis, and there may be associated of the chronic condition that predispose to amyloid deposition, like ALD amyloid, that you have to remember about the light chain immunoglobulin amyloid, and AA, that amyloid, that is SAG, if you remember it. Now this amyloid, if get deposited on the mesenterium, you know that there are the structure of the glomerulus, and the glomerulus mesenterium is a connective tissue, and if that connective tissue get deposited by amyloid, then that will progress to nephrotic syndrome. Okay, now coming on to the light microscope finding, if you do the Congo red stain, if you have remember the pathology chapter, and there will be the Congo red, then there will be a, actually if you remember the chapter, there will be like this Congo red positive, and if we examine under the polarized light, then this will appear as a apple green fringes on the polarized light due to amyloid deposition in the mesenterium. So what will be the light microscopic finding? Congo red stain positive, and that will show apple green fringes under the polarized light due to amyloid deposition in the mesenterium. So what we need to remember about amyloidosis: systemic disease manifestation of amyloidosis, kidney is the most commonly given organ. What is the positive? Congo red stain positive and apple green fringes under the polarized light. If you remember this ones, that is enough for amyloidosis due to nephrotic syndrome. Now let's move to the diabetic glomerular nephropathy. You know that diabetes, the kidney will be involved, there will be the diabetic nephropathy, and this nephropathy will finally lead to the other damage to the kidney, and one of the presentation will be nephrotic syndrome as well. Okay, so even that will lead to chronic renal failure, and it is most common. Diabetic glomerular nephropathy, renal failure, in distress renal failure is most common in United States actually. Okay, so when we develop the diabetes, there will be the increase in glucose level in your blood, and since there is increased glucose level in your blood, there will be glycosylation. This will be non-enzymatic. There is no enzyme involved. Due to the high glucose level, it has now glycosylation with the glomerular basement membrane. Since glomerular basement membrane has been glycosylized, then there will be increase in permeability. So your glomerular basement membrane will be leaky, and there will be a increased tendency to leak of your protein. Okay, and as well as there will be thickening due to hyalin atherosclerosis. So what we have found in the glomerular basement membrane, permeability is increased to the protein. When the same non-enzymatic glycosylation if occurs in the afferent and efferent arteriole, you have to remember that efferent arterioles, that exit efferent arteriole is more affected than efferent arteriole. That you have to remember. Since efferent is more affected by this non-enzymatic glycosylation of the efferent arteriole, there occurs the hyalin atherosclerosis. And you remember, if there is hyalin atherosclerosis, the wall will get thickened. The collagen will leak there, and the wall will be thickened. Since there is a wall is thickened, this wall is thickened. What happens? The pressure has been, the blood vessel passing through will be less. The pressure will be more. So the pressure will be more. The pressure will be goes back to the glomerulus. So there will be increased pressure inside the glomerulus, and so since there is increased pressure, that actually will lead to the high glomerular filtration pressure. The pressure of glomerular filtration will be high. There will be increased GFR, but this high filtration pressure will also lead to microalbuminuria. I have already mentioned that since non-enzymatic glycosylation of your glomerular basement membrane leads to increased permeability. Now, since there is backward pressure, high filtration pressure due to hyaline arteriosclerosis of your efferent arteriole. Now there is more filtration pressure. Since there is more filtration pressure and increased permeability, now albumin will, microalbumin will occur, and this albumin will leak out. Eventually that will progress to nephrotic syndrome. And why nephrotic syndrome has progressed? Because this sclerosis of the mesangium occur. The mesangium, the connective tissue present over there, will be sclerosis and of the mesangium, and that will appear actually as a Kimmel-Still-Wilson nodule. Okay, you are understanding my point? And since this is there are two forces. One is hyaline arteriosclerosis that has built up the pressure, and another is angiotensin 2. If you remember angiotensin 2, then that will cause the efferent arterial constriction, and that is always present in your body due to renin-angiotensin aldosterone mechanism that continuously amount of secretion in your body. Now, if you use this angiotensin converting enzyme, ACI inhibitor, then that angiotensin 1 will not, renin will convert into angiotensin 1, and angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme. If we inhibit the enzyme, 1 will not convert into 2, and since there is no 2, then the additional vasoconstriction of your efferent artery will be not maintained, and this will what? Delay the progress of your development of glomerulosclerosis, sclerosis of your mesangium, or will delay the damage that occurs to the glomerulus, reduce the microalbuminuria. Even if your diabetic patient, ACI inhibitor is usually given to prevent this nephropathy, this microalbuminuria. Okay, so that is very important clinically point of view. Now coming to the characteristic of the disease. The disease, if you examine on the light microscope, there will be a mesangial expansion that you have understood. Pleural membrane will be, GBM will be thickened due to your glycosylation and hyaline arteriosclerosis, and there will be another additional finding that is characterized sclerosis of the mesangium, and sclerosis of the mesangium will appear as the Kimmel-Still-Wilson nodule, and that is eosinophilic nodular glomerulosclerosis. So when you see a light microscope in LC instant, then you will find a eosinophilic nodular glomerulosclerosis. It is known as the Kimmel-Still-Wilson lesion, and this is the glomerulus. Then a certain part will be sclerosis and pink, another will have normal glomeruli, then the other again mesangial sclerosis will present, and this Kimmel-Still-Wilson nodules is a characteristic of your diabetic glomerulonephropathy, which is responsible for nephrotic syndrome. And this you need to remember for your book. So, in nutshell, this amyloidosis and diabetic glomerulonephropathy, these are the systemic cause of your nephrotic syndrome. Okay, let's end over here and we'll discuss further in next lecture. Thank you.